Hello, welcome everyone. We're going to give it 1 minute while everyone comes into the room, and then we'll get started with our webinar today. Thank you so much for joining us. Okay, well, I'm going to go ahead and get started. We have almost 500 people here to join us on this webinar today, which is really amazing. I want to thank you all for joining us for this monthly Anticoagulation Forum webinar. My name is Geoff Barnes. I'm part of the webinar team, and I'm excited to help lead this presentation today on lessons learned from DOAC claims-based observational studies. I have a wonderful group of presenters who are going to be joining me today. They include Dr. Wayne Ray, who's Professor of Health Policy at Vanderbilt University, as well as Dr. Kathy Murray, who's Professor of Medicine and Pharmacology, also at Vanderbilt University. And you'll recognize two of our excellent webinar team members, Dr. Arthur Allen, who's an anticoagulation program manager at the VA Salt Lake City, as well as Dr. Deborah Siegel, who's Associate Professor in the Department of Medicine at the University of Ottawa. These are some of the disclosures for our various presenters today, and they do largely relate to companies that make different anticoagulants. As with many of our webinars, you can claim a certificate credit for this, and you can go to this link. We will include this in the chat so that you can claim your credits after this session. So today, we're going to be talking about this study that came out right at the end of 2021. This was a paper that was published in JAMA. The title is Association of Rivaroxaban versus Apixaban with Major Ischemic or Hemorrhagic Events in Patients with Atrial Fibrillation. And you can see the first author, Wayne, as well as the senior author, Kathy, are joining us today. I'm going to present the slides, and then I'm asking them for their comment, and they'll join us for some Q&A. As a reminder, as this presentation goes along, please enter any questions you have into the Q&A box, and we'll get to those in the second half of the presentation. Now, as a little bit of background, we know that Apixaban and Rivaroxaban are our two most commonly used direct oral anticoagulants, particularly for treating patients who have atrial fibrillation. And they have very similar mechanisms of action. They're both 10A inhibitors. They also have fairly similar elimination half-lives. Apixaban is estimated to have an elimination half-life of 8 to 15 hours, while Rivaroxaban is estimated to have an elimination half-life of 9 to 13 hours. However, when they were going through their development process, there was a key difference in whether they were planned to be dosed once a day, in the case of Rivaroxaban, or twice a day in the case of Apixaban for the prevention of stroke and systemic embolism in atrial fibrillation. Now that has some interesting implications. You can see here from this study where we looked at the plasma levels of these different drugs that there's quite a bit of variation. On the left side of the screen, you'll see the Rivaroxaban plasma levels. Now for a typical patient with atrial fibrillation, they're represented by that dotted black line that you see in the middle. And when they take a pill, you can see the plasma levels increase quite quickly over about 1 to 2 hours. They peak, and then they slowly come down over a case of 24 hours. So you can see that there is a reasonably high peak, and then you fall into this trough area by about the 12 to 16 hour mark. Yet there are various factors that influence how high those peaks are, and therefore how quickly you come back down to the trough levels. Things like hepatic impairment, renal impairment, and use of different drugs that may interact with either P-glycoprotein or the CYP3A4 metabolism process. Now that's different than if you look on the right-hand side with Apixaban, because this was a twice-a-day dosed medication. So the overall dose is a little lower. Your peaks as compared to your troughs are much closer together. You don't get quite as high a peak and therefore as low a trough with this twice daily dosing. Again, the typical AFib patient is in the dotted black line, and you can see how differences in weight, renal function, or drug-drug interaction influence those as they go up and down. And so understanding this data really raised the question for the study authors, do the relative peak concentration differences between Rivaroxaban and Apixaban lead to differences in bleeding or even other efficacy outcomes in their use for patients with atrial fibrillation. So that was the motivating factor behind this particular study. Now, the way they conducted this study was they used a US Medicare claims analysis. So these were patients who had hospital stays, outpatient visits, pharmacy, and nursing home claims. All of the study participants had to have Medicare Parts A and B, which is known as the fee for service, as well as Medicare Part D, the prescription drug coverage. That way you could get information about their diagnoses, their comorbidities, and their medication use. And to ensure that that was relatively complete, all of the participants had to have continuous enrollment in Medicare's Part A, B, and D for 1 year prior to the time they received their Apixaban or Rivaroxaban prescription. Now, because Medicare is largely patients who are 65 and older, or a population of 65 and older, that was limited to that age group, and they do have complete demographics there. And they looked for folks who had one or more fill of either Rivaroxaban or Apixaban. And they limited this to the doses that are typically used for atrial fibrillation. So for Rivaroxaban, that would be either the 20 milligram standard dose or the 15 milligram reduced dose. And for Apixaban, that would be the 5 milligram standard dose and the 2.5 milligram reduced dose. They also importantly had to have atrial fibrillation on the diagnosis codes. And they looked between January of 2013 and November of 2018 to identify and follow patients. Now, they had a number of exclusions, and these would be things you would typically think of, patients who were terminally ill or long-term care residents. They did exclude patients with mitral valve stenosis because that is still listed as an exclusion in the FDA package label. They also excluded patients with severe kidney disease. They defined that as stage 4 to 5 or end-stage renal disease. They also excluded folks with prior use of an oral anticoagulant in the last 12 months, really trying to get at new users of anticoagulation. Lastly, they excluded anyone with a recent stroke or bleeding-related hospitalization within 30 days because they wanted to identify new ischemic or bleeding events. They didn't want to pick up those claims from the prior recent event. Now, this cohort was followed for up to 4 years, and patients would stop for any number of reasons. If they had a supply gap in their anticoagulant, maybe that was a signal they stopped taking it. If they switched to a different anticoagulant or changed their dose, developed advanced renal insufficiency, lost insurance coverage. And then, of course, the important ones were the study outcomes or deaths. So the first study outcome was the end of follow-up. They censored patients there. And the study outcomes they looked at were major ischemic or hemorrhagic events. So we're looking at ischemic stroke, systemic embolism, hemorrhagic stroke, intracranial bleeding, and any fatal extracranial bleed where a death was identified within 30 days. They also looked at non-fatal bleeding and all-cause mortality, and they did this using the principal discharge codes from hospitalization. Now, they used a propensity score analysis method, and this is something I want to talk about a little bit because you'll see this in many studies, and I want folks to understand exactly what this means. When we do a randomized trial, we randomly put patients into 2 or more different treatment arms, and so we can assume that they're pretty similar when we randomize them. But in an observational study, that's not always the case. There may be reasons that people got one treatment over another. Say they received Rivaroxaban as compared to Apixaban. So you can create a statistical score that estimates the propensity or the likelihood that you receive one treatment, let's say Rivaroxaban, as compared to another treatment, Apixaban. And we can calculate that score for every patient in the study. So every patient, as you see in this top line here, where you've got these blue and red individuals representing different treatments, is given a different score. Now, if you use a propensity matching approach, you find different people who have similar or matching scores, and you line them up, and that becomes your final group for analysis. So you get a very similar looking set of patients to study your question. However, you'll notice that we started with 8 patients, and when we use propensity score matching, we ended up with only 6, because not every person who gets drug A will have a matching pair in drug B. So you tend to shrink the size of your study cohort a little bit. A different way to use a propensity score, and that's what was done in this particular study, is to use something called the inverse probability of treatment weighting. Again, you take those same 8 people, you calculate that same propensity for getting treatment A versus B, getting Rivaroxaban versus Apixaban as an example, but then you give each of those individuals a different weight so that at the end, the overall weighted estimates of these two groups look the same. This allows you to keep all of your patients or the vast majority of your patients in your study cohort, but they don't necessarily line up one-to-one like they would in a match. So it's different ways of using the statistical method. In this particular study, they had 208 different covariates, so 208 different factors that they used to estimate the propensity or the likelihood that patients would receive one drug, say Rivaroxaban, as compared to another, say Apixaban. And these were things like demographics, comorbidities, and other medications those patients may be taking. Now, they started with well over 2 million patients who were in the fee-for-service Medicare database and also had the Part D claims with a Rivaroxaban or Apixaban prescription. But then they started excluding people for different reasons, such as making sure that there were prescriptions filled and outpatient visits, such as patients who were not terminally ill, making sure that the doses of the medications were those that were approved for atrial fibrillation. As an example, not using that CAD or PAD dose of Rivaroxaban. They also had to exclude people who had prior use of an oral anticoagulant in the last year, as well as patients who had other indications. Maybe they also had a venous thromboembolism indication, severe kidney disease, things like that. So at the end of the day, they had 581,000 patients who met their study criteria. About 227,000 who were prescribed Rivaroxaban, and about 354,000 who were prescribed Apixaban, and those were included in their final analysis. Now, I pulled just a couple elements from their table 1, their list of descriptors, because these were the ones I thought might be most interesting to talk about. You can see here that approximately 1/4 of the total cohort received a reduced dose of either Rivaroxaban or Apixaban, and that was fairly similar in the two groups. That the mean age was similar, about 77, and that there was a pretty good split of men and women. There was about a 7.5% non-white population, and about half the time, cardiologists had prescribed these medications. Now, this was a fairly high thrombotic risk group. The mean CHADS VAS score here was 4 to 4.5, so that's fairly high, and approximately 9% of these folks had had a prior stroke. There was good representation of chronic kidney disease, about 16% in both groups. And interestingly, and this relates to some prior work that these authors had done, about a third, just shy of a third of patients were prescribed a proton pump inhibitor. About 17% were using non-steroidal anti-inflammatory medications, and a similar proportion were using P2Y12 antiplatelet agents. Here's the main take-home slides, the main sort of outcome slides. You can see on the left is the primary outcome in a cumulative incidence plot. So the yellow line represents the patients who were treated with Rivaroxaban, and the darker blue line represents the patients who were treated with Apixaban. And as you can see, the adjusted cumulative incidence of both ischemic or hemorrhagic events was higher in the Rivaroxaban group than the Apixaban group. If we go over to the tables, we can actually get the event rates as they were estimated. So for that primary outcome, the Rivaroxaban group had an event rate of 16.1 per 1,000 patient years, as compared to Apixaban, which had a 13.4 per 1,000 patient year. That had a rate difference of 2.7, and that was a statistically significant increase. The hazard ratio was 1.18, and you can see the confidence interval there. So just shy of a 20% increase in the hazard. When you break down the components, such as the ischemic events, the hemorrhagic events, the non-fatal bleeding events, and all-cause mortality, you can see the event rates there as well. And there's general consistency across the board. The non-fatal bleeding probably being the one that stands out, that was a little bit higher in the Rivaroxaban group than the Apixaban group, with a hazard ratio that was around 2. All the rest had hazard ratios a little closer to 1 to 1.2. They also did an interesting analysis. Remember, about a quarter of these patients received a reduced dose of one of these medications. So they looked to see whether this difference, whether the lower rates of outcomes in Apixaban as compared to Rivaroxaban, whether that persisted in the reduced dose versus the standard dose group. And you can see that in the reduced dose, you see both the ischemic and the hemorrhagic outcomes do seem to be lower in the Apixaban group as compared to the Rivaroxaban group. However, in the standard treatment group, that's about 75% of folks here, the ischemic event rates was not different between the two. There was no statistically significant difference, but there still was a difference in the hemorrhagic outcome. So we do see some difference here by the dose selection for both of these drugs. Now, the authors had a couple important conclusions, and we'll get into these in our discussion. They indicated that initiation of Rivaroxaban was associated with a higher risk of major ischemic and hemorrhagic events as compared to Apixaban in a population of Medicare beneficiaries 65 or older with AFib. They also noted that this was the largest cohort to compare DOACs head-to-head in this size population of 65 or older Medicare patients, and that the increased risk of ischemic and hemorrhagic events with Rivaroxaban seemed to be more pronounced for those that had reduced dose DOAC as compared to the standard dose. Now, they did list a couple very important limitations that we need to discuss. This was an observational study, and with every observational study, there's always the potential for residual confounding, things that were unable to be measured that might be different between the groups. However, they used a very robust propensity score to try and minimize that. They also recognize this is a claims-based analysis, and there's always the potential to misclassify an exposure. So the reason somebody gets in, say atrial fibrillation or a medication, also an outcome. We have to rely simply on the billing claims, and that there was no data available here on medication adherence. So we don't know how well the patients actually took their meds. They also acknowledge that despite the motivation being those drug level studies that they had seen, there were no actual drug level data in this particular study. And this was limited to an older population who had Medicare Parts A, B, and D together. So that may be somewhat limiting. I think it's important for us to also take a step back and have this broader discussion about what are the strengths and some of the drawbacks of randomized trials as compared to observational studies. They're both important and they're complementary, but they're not interchangeable. So as an example, in a randomized trial, there really shouldn't be any of this unmeasured confounding or selection bias, because every person who's entered into that trial needs to be eligible for all the different treatments. In this case, you would have both treatments available. However, in an observational study, that may not always be the case. You need to ask yourself, why did a patient receive treatment A as compared to treatment B? Why did they receive Rivaroxaban as compared to Apixaban, as an example? And that we try to adjust for that with various statistical techniques, but we can't always eliminate that perfectly. Now, sample size or the ability to detect a difference in your outcome can be limited in randomized trials. They often don't have quite as large a population. That's something that's often overcome in an observational study. You saw here, we were talking about hundreds of thousands of patients, much more power to detect differences. Internal validity, how well did people actually adhere to the treatments we think they were on? In a randomized trial, that's usually pretty high. We know that a treatment was given because there's such close oversight. We have high quality abstraction of comorbidity data and medication data, and we often have good access to laboratory data. So we tend to know a lot and trust the data we have in a randomized trial. This sometimes can be a concern in an observational study. We don't actually know that treatments happen. You may have had a fill, but did the patient take the medication? That's always a question. We don't know whether the comorbidity data or other medication data is completely accurate. Sometimes things end up in a claims or end up in a medical record that may not be completely reflective. And it's hard to assess the severity of an illness when we're simply relying on claims. Not all of the claims have very granular data on severity. I'm thinking here like renal insufficiency, or even if they do, we as physicians and healthcare providers don't always do a good job of making those billing claims linked to the actual severity of a patient's disease. And really, there's a lack of laboratory data. We don't have the value of a lab. We just know that a lab was drawn, so that can be limiting. When we look at these studies, we have to ask about how they externalize, or how can we generalize the findings of the study to our patients? And in a randomized trial, this sometimes can be limited. There are lots of inclusion and exclusion criteria to get a very somewhat limited but eligible population for a trial. Does that necessarily reflect the patient you're seeing in clinic? In an observational study, that can be a problem, but often is not, because they're often a bit broader in their inclusion and exclusion criteria. And then, of course, lastly, what about follow-up and loss to follow-up? In a randomized trial, they tend to do a pretty good job of following patients and knowing where they're at and making sure they have complete data. But in an observational study, we often lose patients because they don't come back to the healthcare system or they lose insurance. So sometimes the follow-up period can actually be much shorter. And that's something we have to be thoughtful of when we look at these large observational and claims-based studies. So at this time, I'm going to go ahead and stop. I'm going to ask for some comments, but encourage all of you to please continue to put your questions into the Q&A so we can continue to have this discussion. But I'd like to invite Kathy and Wayne to come back on, and I'd love to hear your reactions to the data that was just presented. What did I miss? What did I get wrong? What other comments do you have? Wayne, did you want to start us out?
Yes, thanks, Geoff, for a great presentation. I wanted to make two comments. One kind of minor. You spoke about adherence, but actually we're not quite in as bad shape as you might think with these types of data, because patients do refill their prescriptions. And so when you see them refilling them regularly, you can have some sense of adherence. And there are various measures called, for example, the medication possession ratio, which are used, and we found those ratios in excess of 90%. So you do have one measure of adherence. A larger issue, I think, when you were mentioning the strengths and limitations of randomized trials versus observational studies, one of the greatest limitations of randomized trials is that oftentimes the questions that are most clinically relevant have never been studied in a randomized trial. So, for example, where is the large randomized trial of Rivaroxaban versus Apixaban? So it's not as though we can say, well, here are the strengths of the randomized trial, here are the strengths of the observational study, which one shall we pick? There is no randomized trial, and it's probably unlikely that there ever will be one with adequate power.
Yeah, those are two excellent points. And that's why I think it's so important to understand that these are complementary study designs, and we have to pull from them what information we can get, while also recognizing no study is 100% perfect. And so being able to interpret them in totality is really helpful. Thanks for that. Kathy, any other comments that you had to share?
No, Geoff, that was excellent. I'm glad you led off with the slide that you did, showing the variability in plasma concentrations and the greater variability that we see with Rivaroxaban. And that was a motivating factor for doing this study.
Awesome. Arthur, I'm sure we're getting lots of questions that are coming in. Did you want to maybe kick us off in our Q&A section?
Sure, you betcha. So Geoff, as usual, eloquently presented, and I congratulate the authors on just an important, great paper. We've seen a number of these studies, and the limitations that you point out are so important. One thing I would say is that, everybody has kind of wanted to know, which drug is best, which drug is safest for a long time. And I think it's important to orient ourselves back to the warfarin days, right? To say all of these drugs are as effective or more effective than warfarin, and they're all safer than warfarin. And so what we're left with are kind of arguments over what are ultimately relatively small differences, if in fact the differences exist. So I think it's important to orient us to that. We have important drugs here, important decisions to make in using them. Sometimes we may favor one drug based on its being once a day, and they're more likely to put the pill in their mouth and swallow it versus it being twice a day. So there's a lot that goes into dose selection for both excellent agents. So one of the things that I would like to speak to, we did see in the presentation the amount of patients that were on dose reduced regimens. But in these types of studies, you often can't control for whether or not that was the right decision. And in fact, if they were on full dose, was that the right dose? If they were on reduced dose, was that the right dose? We know from many papers that the off-label dosing of these drugs in the real world is in the double digits, oftentimes in the double-digit percentage range. So, can the author speak to what was done to control for that, if anything?
Well, Wayne, go ahead.
I was going to say, to start with, we did do the propensity score calculations separately for the 2 doses. So to the extent that variables that differentiated between high dose and low dose were accurate, we did adjust for that in the propensity score calculations. So I think, but beyond that, if patients are giving too low a dose of Rivaroxaban because they're frightened of bleeding, which is a very common scenario, I guess what I would say, that's just part of the way people are using it. So if the way that the folks on the front line use it is inappropriate and that leads to poorer outcomes, then that needs to be taken into account in evaluating the overall clinical effectiveness.
Exactly. This is more of a real world scenario of what's going on.
Right, and to that point, I noticed within the slide deck, over 16% of patients were co-prescribed NSAIDs. That's going to drive bleeding rate far more than which agent the patient is on, and yet that's something that should be, from an operational standpoint, that's something we should be targeting, right? It's that high use of NSAIDs and antiplatelet agents. Deb, you have a question lined up for us?
Sure. Thank you so much for the presentation and for the initial comments. This is such an important conversation that we have all of the time. I just wanted to say at the outset that there will be randomized controlled trial data coming out. I have a colleague, we're doing an international randomized trial of Rivaroxaban versus Apixaban for the acute treatment of VTE. And she just got multi-million-dollar grant funded for the similar comparison for atrial fibrillation. So we are looking forward to having some randomized controlled trial data. Now, whether or not it will be powered and, I guess remains to be seen, but that's very exciting. One of the things I think I wanted to mention, and we already touched on it a little bit, is just when clinicians are thinking about these questions, which we do all the time, just understanding a little bit about, you touched on this a little bit, Wayne, about the issues of randomized trials, and of course there are benefits and disadvantages of doing randomized trials versus observational studies, and they are certainly complementary. But one of the things I think that you get from a randomized trial that's important for the internal validity is this concept of intention to treat. And so that, helps disperse or ensure that there isn't bias in terms of which patients are getting which drug. And I just thought maybe you could touch on that a little bit in terms of some of the things that you measured in this study to help explain, to account for some of the differences in the populations at baseline and how that might be different in a randomized trial.
Sure. So a couple of points. First is that, as you say, in a clinical trial, the investigators will usually move heaven and earth to keep patients on their assigned treatments. And, they've got all kinds of measures in place to do that. Sometimes they actually even have like pre-screening to make the participants jump over some barriers just to see if they're the kind of people who will follow instructions. On the other hand, in the real world, none of that is present. And you also have drugs that are very expensive that people who are on limited budgets oftentimes have to pay for. So you see much greater rates of discontinuation. That said, what we found was that the discontinuation was more frequent with Rivaroxaban than with Apixaban. And when you look in the literature, again, as I said, you oftentimes see that bleeding is a frequent reason for discontinuation. So to the extent that there's bias introduced by loss of follow-up and the people who leave often have poorer outcomes, I would say that it's probably conservative, that all the extra folks who quit using Rivaroxaban might go on to have poorer outcomes, but they're not included in our analysis.
Can I just ask a question about so patients were included in this study, they were new users of these medications, and maybe just so people understand, when you're assembling the cohort, we have specific criteria to include people in this cohort, and Geoff reviewed some of those things, and it's actually quite detailed in the study. in the paper itself. But one of the things that I was wondering about is how people exit the study. So when did they come out of follow-up? And I wondered a little bit about how could that influence results. Maybe you partially answered that already, but just to understand, as I was thinking a little bit about intention to treat, even if people leave your study for whatever reason, they're still analyzed according to the group that they were assigned. Whereas for this type of study, people would leave the group for different reasons if they switched medications or discontinued medications for whatever reason. Maybe just speak a little bit about that.
Yes, the reasons for ending follow-up were, first, the most common reason was they stopped taking the drug they started on. And the way we define that is they had a 30-day gap between the last prescribed day of supply and a subsequent prescription. So they'd been, at least according to the days of supply, off the drug for at least 30 days. And the other reasons were much less common: change in dose, switching, end of the study, study endpoint, loss of full Medicaid coverage, Medicare coverage, et cetera. And again, you get a difference, and this is one of the areas where you can think, if you really want to know what the effect of the drug is without any alternate factors confusing the issue, then you'd like to just keep people on the drug continuously. On the other hand, people are using these in the real world, so a study like ours may provide better information on, out on the front lines, how the drugs are actually working. And that's just a trade-off.
Interesting, thank you. We have a couple of questions about prior work that has been done, and I'll combine a couple of questions here. There's one question about did you consider utilizing warfarin as a comparator, or has that been done? I'll answer it, yes, that's been done. You guys can speak to the details of that. Was there a consideration in using warfarin, and can you speak to maybe how this paper compares to or kind of aligns with other work done in this arena?
So why not look at warfarin? Well, as someone who's a methodologist, I would have enjoyed doing that because it would have been a lot of fun. But I think that the point is it wouldn't be as clinically relevant. And there's so much data comparing, starting with the pivotal trials, as I think you all mentioned earlier, which all of the DOACs are non-inferior to warfarin. They're much easier to use in clinical practice. And Apixaban is actually superior, according to data from the pivotal trial. And numerous real world data studies have essentially shown similar findings. So what would be the point in taking up our time and the reader's attention, kind of going over that territory again? And you may also wonder why we focused on Apixaban and Rivaroxaban, but there are other DOACs, but these are the ones that people are using, and we wanted our findings to be as clinically relevant as possible. The easiest thing to understand is a head-to-head comparison between the two horses that are in the lead in the race. And so that's what we did. Not to say that other studies wouldn't be fun or interesting.
Yeah, I think had you done that, Kathy could have worn a "been there, done that" t-shirt on this webinar, and then we would have, kind of answered our own question.
So there's a lot of questions, I think, about that are coming in through the chat, and people are asking questions about the issue of dosing and appropriate dosing or not appropriate dosing, which can be tricky to establish. And we've talked about that a little bit. One of the questions that I wondered about as well was, the degree of dose reduction is different for the two drugs, and whether or not you think that, that could also have some sort of impact on the outcomes that we're seeing. So for example, Apixaban has a 50% dose reduction, and the Rivaroxaban is only a 25% dose reduction. But there were some other, I think, important factors that people were raising, like things like body weight, renal function. Are there any planned analyses looking at some of those things that could help explain the results in more detail for people?
Well, I think, those are very interesting questions. If you just do a PubMed search on DOACs and look at the most recent stuff, a surprising number are on obesity, because I guess you all might be uncomfortable giving a 40 kilogram and 150 kilogram person the same dose. but we don't have weight. That's one of the limitations. We don't have body mass index. And so for us to study it, there was back decades ago when I was starting out, one of my mentors said that people, epidemiologists always deal with dirty data, and the trick is to do so with a clean mind and not pushing the data too far for things like obesity, which we really don't have good information on, is part of that. So those are interesting questions. The data we have are not the resource to address them.
I'll ask Kathy one. There's a good question here. We looked at all of the different, within the propensity scoring about trying to control for a number of different factors. It seems that Chad's basket has bled may not have been kind of, could we control for that or align patients by those kind of scoring mechanisms? I have a feeling it has to do with what you have access to with the code, but can you speak to, is that a limitation or is it impossibility based on the data?
Just by balancing on comorbidities, it turns out the CHA2DS2-VASc score was identical between the two groups after propensity matching. So I think the approach we had did a reasonably good job of coming up with a relatively balanced population.
Arthur, could I jump in here? And Wayne, I know you spend a lot of your time thinking about, methods for these observational studies. And I'm wondering if you could share with us a little bit about maybe how you choose a propensity score approach, like why choose the inverse probability weighting, or are there reasons to maybe choose something else? Are there new methods, coming out that we should be looking for in studies? What should we as clinicians be aware of when we read a study like this that uses a propensity score approach?
Well, I guess old timers like myself have, seen the advent of this technique, which has really revolutionized how we can do these studies, because it's now practical to control for 200 covariates, which back when I was starting out, if we could control for, 7, we were happy. So in my mind, many of the propensity score techniques really give very similar findings, and it's kind of a matter of the details as to which one you used. You may wonder why we didn't use matching, for example, which is often easier to understand. Well, one of the reasons is that, as you all probably know, Apixaban doesn't really need our efforts. It's winning the race anyway, if you look at the trends. I mean, its utilization is outstripping that of Rivaroxaban. So had we done propensity score matching, our cohort would have been weighted towards the earlier years when Rivaroxaban was more popular. And we thought that would be not the right thing to do. We wanted to give it to reflect the current practice as much as past practice. So that was the reason for weighting. But those are really sort of specialist issues. I think the key thing for consumers to think about is to look into the details, because from 10,000 feet, these studies all look fairly straightforward, but it's all the details. Like, are you using data that's relatively complete, like the US Medicare data? Are you accounting for the major factors you can? Is your measure of exposure something that's reasonable? So on all these little details, that's where really the problems typically lie.
I could echo that, in that when this study was performed, as all studies with Wayne, 99.9% of the effort was spent outlining the details, going over covariates, making sure the details were correct before any analysis was done.
All right.
I lost track of where we were here.
Yeah, there's so
We were
many
just
questions
distracted
coming in.
there's a lot of questions coming in,
There's
so
a lot
we
of
want to
good
make
stuff.
sure that
Hey,
we're addressing them.
We're trying to listen to these guys too, so apologize.
Yeah, exactly.
So there are some questions about, what are the status of head-to-head randomized controlled trials of even Apixaban? And really, I think you answered that, Wayne, saying probably ain't going to happen, right? We don't have, there's not a lot of impetus to do randomized controlled trials comparing to competing agents. Would you agree with that?
I think, didn't you say, Deb, that a large trial was going to be launched? I mean, I think it's So great, if it happens, it'll have to have quite large sample size.
Yeah.
So
Yeah, thousands of patients.
Oh,
So we'll look now. The study that's being done is a colleague of mine, Dr. Lena Castellucci in Ottawa. She's the principal investigator. And the VTE trial, acute VTE trial, venous thromboembolism trial, has enrolled, I believe, over 1,500 patients at this point. So we'll be looking for more, obviously. And I'm not certain about what the sample size, the overall sample size will be, but it's in the thousands. And she's just about to start a similar type of randomized trial. So really, these are, comparative effectiveness trials. And the main outcomes are bleeding. So looking for superiority on bleeding. So adverse events, which is really important. But both efficacy and safety are important. But my understanding is that they're powered on bleeding. So
Geoff, I wonder if I can.
It'll be some years. So that's the nice thing about observational data too, right? You can you can analyze many years of many, hundreds of thousands of patients, and you don't have to wait 10 years to do that, which is really helpful, I think, for getting results to clinicians in clinical practice. One of the things that people are wondering about, a few patients have asked this question of, if there's two questions that I would sort of say that I think about with these results. One of them is, how would you explain the difference between these drugs in terms of to a patient? So how do these results translate for someone who's about to start anticoagulants? And then the second kind of corollary to that would be, based on these data, do you think, or is there an opportunity to measure drug levels, if that's kind of one of our hypotheses about why we're seeing these effects? And they're two separate but related questions. Is there a way to fine tune that for individual patients? So one would be like, what are you going to tell patients about this? How much or what are they getting? Somebody had asked about number needed to harm and number needed to treat in the chat box, but really just being able to translate that into a patient.
So I think our job as healthcare providers is to give the patient the safest therapy. If efficacy is equal, to give the patient the safest therapy. So I'm not sure I would let the patient decide which drug to get. Based on these data and others that have come before it, our arrhythmia group, pretty much down to a person, and it's a pretty large arrhythmia group at Vanderbilt, prescribe Apixaban. And that's our practice. And I honestly cannot, in preparation for this, I think I was thinking about, is there a situation where you would prescribe Rivaroxaban? And honestly, I can't think of one. If you're talking about compliance, I'm not sure once a day is necessarily going to really solve that problem. I think it's our job to provide this information to the patients, what we think is the safest drug. Interestingly, with respect to dosing and plasma concentrations, that is a great question, because both of these drugs are eliminated by both CYP3A4 as well as P-glycoprotein. What does that mean? Well, let me just refresh everyone's memory that three of the more potent drugs to inhibit these enzymes include amiodarone, verapamil, and diltiazem. So we're not talking about trivial drug interactions. We're talking about major things that can really affect. So do we wish we had plasma concentrations? Absolutely. Can we extrapolate from the studies that have been done to show that there's a 50% increase in drug concentration with amiodarone, or 70% increase? I mean, I think when it gets to patients, the drugs are also renally excreted, so it gets even more complicated. So personally, I very much wish we had plasma concentrations available because of, in particular, the drug-drug interactions.
Maybe we'll ask for Geoff to comment. I don't know if you wanted to speak to that a little bit about decision-making and how to talk to patients about this.
Yeah, Kathy, I really appreciate your insights in this. I might have a slightly different take on it. And, I think this comes back to some of the questions we've seen in the audience, which is, first off, both of these drugs are highly effective at preventing stroke and systemic embolism in patients with AFib, right? That was established in the large phase 3 clinical trials, showing that they are at least as good, if not better, than warfarin. So I think that, to me, this is not a question that Riva or Apixaban is or is not effective. I think it's really trying to do some comparisons. And I think there's a number of reasons that people may choose to go with one or the other: familiarity, frequency. I see a lot of people who tell me they can't take twice-a-day dosing or it's not reliable, things like that. But I also wanted to maybe ask you a little bit to get into this. Clearly, we had a statistically significant difference in bleeding and ischemic events, although the efficacy piece wasn't different if you're using the standard dose. So that sort of, for 75% of people was reassuring. But these outcomes were measured on a per 1,000 patient years. So if the risk difference in your primary outcome was, 2.7 per 1,000 patient years, what does that translate into? Does the average patient, should they expect to see a big difference in sort of the likelihood of having a bleeding event or stroke event? How do you conceptualize that against, percentages and per 100 patient years, which I think many people are used to thinking about?
Let me just point out one of the outcomes you haven't mentioned, which is the non-fatal bleeding. All the bleeding. It didn't come up in the presentation, but that actually required a hospital admission. So these are not patients who, come into the doctor with, a low hematocrit or something. These are people who go to the hospital. And the number needed to harm was around 50. So I would say that whatever you're thinking, that is a clinically important number. The number needed to harm is smaller for the major ischemic, or is greater, so the absolute risk is lower, but these are strokes, intracranial bleeds, which sometimes neurologists will tell you is a fate worse than death, and death. So these are not trivial outcomes. In many areas of medicine, the numbers needed to harm, I'm just looking at, are around 300. So oftentimes treatments are decided on the basis of numbers needed to harm of that magnitude. So I guess from my opinion, and if I were talking to a family member, for example, those numbers needed to harm are important enough to guide clinical practice.
I couldn't have said it better.
We've had, this is a bit off topic, but it keeps coming up and it's on people's minds. And I know, Geoff, you've done some work with this. We have some questions about the CVS Caremark decision to exclude Apixaban from its preferred drug list. And specifically, one of the questions is, what's the AC Forum's stance, or what are they doing about it? Is that something that you feel you can speak to here?
Yeah, I would say, the AC Forum is certainly in favor of patients and their physicians or their healthcare providers having the ability to select the best therapy for that individual patient, whatever it may be, and that those be available to patients. So that individual decision-making opportunity is something that we really highly value. The Anticoagulation Forum is working with a number of different organizations to try and raise awareness about this and help address this concern. There's going to be a slide here at the end of the presentation with a little more information. A small group of us through a number of different societies are meeting with the CVS Caremark leaders and expressing our concern about having such a limited formulary, and recognizing that patients and their physicians need to have opportunities to select the best agent, and that we shouldn't limit to just one, but we should have multiple choices available, because individual patients need individual therapies. And that should be something that a patient and their physician or their healthcare provider are able to decide together. Deb, I know we're getting close to the end of the hour. Do we have any other questions before we get to the wrap-up period?
One of the other things, the final thing maybe I wanted to add is just thinking about how to apply the results of this study to clinical practices, and just think about who was included in the study and who was not included in the study. And so people who are over the age of my understanding is that it included people that were over the age of 65. Do you think that these results would be applicable to younger types of patients or different types of patients based on the analysis that was done? And how should the readers think about that in terms of their clinical practice and individual patients?
I guess I would just point out that first of all, there was a paper in 2020 that did include a younger population that actually had quite similar findings. And I'm just struggling to think mechanistically, apart from perhaps greater baseline risk, why there should be differences between someone who's 67 versus 63. But I think, it is, perhaps the better evidence is this study that came out in the Annals in 2020 that included persons younger than 65.
Okay, well, thank you so much. Thank you, Geoff, for your amazing presentation and overview of this study. Thank you, Wayne and Kathy, for your comments and for your work. And thank you, as always, to Arthur and Deb for your amazing moderating. As we said at the beginning, this is available for credit for pharmacists, physicians, and nurses. And the link is here and in the chat box and on the AC Forum website. I wanted to highlight a new program that the AC Forum just launched. It's Medical Management of PAD Virtual Learning Series. Geoff and Deb were both part of that. So, and there were 5 small videos on practical management for PAD. So if everyone wants to check that out, you can get to it from the AC Forum website or directly from this link here. We also did a rapid resource, which is a quick clinical guidance on this topic. So I hope you'll all check that out. That, along with many other resources, are in the AC Forum Centers of Excellence, including an online literature update that comes out every 2 weeks and highlights the most important papers in the field of anticoagulation. I'm excited to let everyone know that Brigham and Women's Hospital in Boston is launching its first ever pharmacy PGY2 residency in thrombosis and hemostasis. So please let anyone know that's interested. They are accepting applications past the ASHP match, so there may be a good candidate for. I wanted to let everyone know that we are announcing our next boot camp will be May 20 to 21, and it will be both live and enduring, not in person, but live, and registration will be open soon on our website. But we will have a live conference hopefully next year in San Francisco. So please save the date, March 31st to April 2nd, 2023. So I'd like to thank again all of our speakers, everyone for their time joining this webinar. And this webinar series is brought to you by our corporate sponsors. So thank you to all of them. Have a nice day.